Good morning,
Welcome
everyone.
to today's webinar. This
Good morning, everyone. I am Sonia Salamat, Mu Sigma Phi Sorority Batch 1995, speaking on behalf of the Aging and Longevity Webinars team of the Mu Sigma Phi Sorority. We are streaming live from the video conference room of the UP Manila Information Management Service. Our time in Manila is now exactly 12 noon. We have about 900 participants registered to this webinar from all over the Philippines and from other countries as well. Hello to our viewers from Mindanao, Butuan, Camiguin, Kidapawan, Bukidnon, Tawi-Tawi, and Zamboanga. This webinar series runs every second and last Friday from January to November 2019 and will deliver interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. Today's webinar was awarded 10 PMA CME units for doctors, 1 CPD unit for physicians and pharmacists, and 2 CPD units for nurses. For today's webinar, we are privileged to have a distinguished alumna of the UP College of Medicine, Class 1982, as our speaker. She graduated from the UP College of Medicine in 1982, completed her master's degree in medical anthropology at the University of Connecticut, Yukon Stores in 1992, and completed her doctorate degree in nutrition at Cornell University in 2013. She was a former Chief Science Research Specialist of the Nutritional Assessment and Monitoring Division of the FNRI from 2016 to 2017, and she is currently a Senior Scientist for Human Nutrition at the International Rice Research Institute. She has multiple publications on nutrition and health status of the Philippines, both locally and internationally, and she has received the Philippine Association of Nutrition Service Award from 2014 to 2017. Ladies and gentlemen, we are proud and honored to welcome Dr. Cecilia C. Santos-Acuin, Mu Sigma Phi Sorority Batch 1982.
Good afternoon, everybody. I'm Acuin, Music Mafia Sorority 82, and we are very happy to provide you with this medical webinars on aging and longevity. And this afternoon, I'm going to talk about anemia in the elderly, which is more common than we think and could be a bigger problem than we think. So, shall we start? I declare no conflict of interest. And we'll start with defining anemia and normal hemoglobin, which is not as straightforward as you might think in the elderly, as you will see from this table. So I hope it's clear from wherever you're viewing this. So generally, we follow the WHO thresholds for defining anemia, but there are differences according to gender and according to race. So if you will look at uh, the different categories here, or the different columns from this table, you will see that different sources use different cutoffs. And in fact, in Japan, um, I saw a reference that said they use a cutoff of 11 or 12, which seems to me a little low. But anyway, in the Philippines, we are using, sorry, I lost my slide. We are using the WHO categories, as you will see here. And there is no specific cutoff for the elderly. All of the males above 15 years and above, and females 15 years and above use the same cutoff. So this is what we are following here in our country. Now, uh, if you want to identify iron deficiency anemia, one of the useful parameters that you can use is serum ferritin. But unfortunately, this is not a relatively accessible laboratory test. Nevertheless, if you are able to access this and you are able to get a value for your patients, those that have lower than 15 micrograms per liter are considered to have depleted iron store. So that in uh, together with the hemoglobin levels, and as you will see later from other information that you might get from your CBC, will provide you with the guide to the diagnosis of your elderly patient with anemia. Now, if the prevalence of anemia goes beyond certain thresholds, then they are considered either mild, moderate, or severe. And as you will see later, most of the problems in the elderly are considered in the moderate category. So let's look at prevalence and causes of anemia in the elderly, both at the global and the Philippine situation. This is not a very recent slide, but we couldn't find any distribution of anemia prevalence by age group that's more recent. So what you will see here is that in general, it's about 24% of elderly have some form of anemia. And this worsens as the elders age. So the prevalence, this is from a European hospital setting, the prevalence goes up even up to almost half of the population, especially among men, once they reach their 80s and their 90s. So you will see that on this graph. We do not have this distribution available for our local data because we do not have that many elderlies that are included in the National Nutrition Survey. So the reason why they're able to do this in this study is because they use the hospital setting. And a lot of the elderly with anemia often find themselves already hospitalized. So the in the general rule is that you need to have the hemoglobin of these elders within the 13 to 15 or 130 to 150 grams per liter for women and 140 to 170 grams per liter for men in order to prevent hospitalization and mortality. And this comes from a longitudinal follow-up study in the US. We do not have such longitudinal studies, unfortunately, in the Philippines, and hopefully some of you who are listening will be motivated to do these kinds of research. So the prevalence of anemia in the Philippines among the elderly is very similar to that of the global prevalence. For men, it's 23%, and for women, it's 19.1%. So these are for adults that are at least 60 years of age. But as you can see from the background, the green background information, the age group that actually has the highest prevalence of anemia in our country are those of infants below 1 year of age, and they reach up to 40.5% of infants that have anemia. So the problem of anemia appears to be most marked in the extremes of age, as well as you will see, somewhere below the among pregnant and lactating women. Over time, our prevalence has actually gone down. So in our earlier survey in 2008, the prevalence was as high as 33%. And then this is for all anemias. And then this has already gone down this 2013. We are awaiting the most recent survey, which will come out towards the end of this year because we conducted a survey in 2018. So we will have that data sometime this year, and we will know whether this trend will persist. Not all anemias are due to iron deficiency. And this was a small study that was done in the Philippines among adults, but unfortunately only up to 59 years of age. They did not include the elderly in this study, but it does give us, I think, a ballpark of what are the anemias that are most likely due to nutritional causes and what are the anemias that are due to other causes. And roughly, I would say it's about 1/3 in each category. So you'd have about 1/3 that are due to nutritional anemias, about 1/3 that may be due to hemoglobinopathies, and about 1/3 that are due to other causes. But this is, again, as I said, for adults that are below 60. For adults that are older 60, I think the distribution might be a little different in the sense that I think we will have more of anemias due to other causes, and you will understand that as I go through my presentation later. Okay, I keep on clicking the wrong thing. Um, I'm showing you this slide which shows the severity of anemia by underlying cause because I wanted you to see that the severity is the severity meaning in terms of it's being a public health problem is most pronounced for nutritional anemias, and this is a very accessible in terms of treatment form of anemia. So I would encourage those of you who are uh, working in resource constrained settings to first consider nutritional anemias as the cause of your anemia in the elderly and give a trial of treatment. We'll discuss that further later so that your patients you will be addressing the most common and the most probable cause in your patients. So let's go to the causes of anemia in the elderly. This is a nice graphic that I was able to find. And there are, as I said earlier, three categories. So you have the nutritional anemias or anemias due to nutritional deficiency, that's in the middle. And then on either side, you have uh, the other causes of anemia. So you have what they're calling clonal anemias, which is due to some mutations or genetic abnormalities in the enzymes of your liver. And then on the other side, from the kidney, you have your chronic renal diseases, diseases of inflammation. Now, as you will see, the liver and kidney related anemias, in general, what they do is they depress or suppress production. And so these patients who have these kinds of anemias, they need to be worked up so that you can understand better the underlying cause. And we'll go to that in the next few slides. Let's go to nutritional anemias first. So in general, you would see about a third of anemia cases in elderly are due to nutritional causes. And aside from iron, the other nutrients that usually are deficient are folate and vitamin B12. The folate is related to alcohol use as well as to um, other forms of malnutrition, especially when these elders are unable to eat properly. You need more than just rice in order to meet your other nutrient needs. So you will have to check very carefully if they are able to eat well. And that's why I included there, include dentition in your physical exam, because very often the problem of the elders is as they age, they are having problems with chewing, with swallowing, and that is what is the more common cause of their nutritional deficiencies. Not so much uh, if they do not have other comorbidities, not so much the other comorbidities. B12, of course, is a known deficiency problem among the elders because of atrophic gastritis, which happens very commonly, and there may be deficiencies in the intrinsic factor, which limits the absorption of your B12. So very often you really have to provide a source of B12 to these patients. Now, I'm showing you very quickly lang, the nutrient requirements in adults and focusing on the ones in the elderly. I'm showing this to you because as you will see from the different levels of requirements, the levels of requirements actually increase in your 50s. But we only classify the seniors or the elderlies as 60 and above. So I think we need to be mindful about this, that as you reach your 50s, your nutrient requirements actually change relative to your younger years. And so you might need to increase your intake of certain nutrients. So I hope you will be mindful of that, because it's not just iron or vitamin B12 or folate that you need in order to have good nutrition and prevent anemia. You need a lot of other vitamins too. So usually if you eat a well-balanced diet and you eat it in sufficient amounts and at regular intervals, you shouldn't have any problems, even if you're an elderly. But as I mentioned earlier, the elders have a lot of other problems that may affect the way that they absorb these nutrients. So this is for vitamins, and then the next one is for minerals. So that's where you'll see the iron, but also of importance will be selenium and magnesium. Um, but as I said, if you are eating a well-balanced diet, you should not be worrying about these micronutrients as a general rule. Now, there are other causes that are non-nutritional, as I mentioned earlier. So you have the anemia related to renal insufficiency or to chronic inflammation. There are anemias related to myelodysplastic syndrome and other causes. Um, but many of these need much more intensive workup. So they will need diagnostic workup, and they are also going to need more specialized care. So if these patients happen to be in your area, they're going to need specialized care and you will need to refer them. Now, for the students out there, this is a neat little table that you might want to keep or have a copy of, because it gives you in a nice compact way all of the different categories of anemia and their subtypes. These are not just for the elderly, this is for anemia in general, but it's a nice summary of the causes of anemia. Now, why are we so worried about anemia in the elderly? That's because the consequences of anemia, or even just low normal hemoglobin, are more marked in the elderly. So what you see here is a graph that shows the risk for all-cause mortality for males and for females. And as you will see, the lower the hemoglobin, the higher the risk of mortality up to a certain point. So it's a U-shaped graph, as you will see. So the optimal levels of hemoglobin would fall somewhere between 12 to 15. And then beyond that, your mortality will rise again. And there are other factors related to that, so like thromboembolism and things like that. But in general, it would be good to have your hemoglobin at the range of 12 to 15, because that's where your lowest risk for mortality are. So I mentioned mortality. Anemia in the elderly also increases disease severity. So in whatever the disease is, we have observed that if on top of that disease, the person is anemic, then the signs and symptoms of the disease are more pronounced. If your elder is also anemic, in general, there is poorer response to therapies. For example, radiotherapy for cancer depends on the adequate oxygen delivery by hemoglobin for optimal tumor cell killing. And so if your patient is anemic, then there is compromised oxygen delivery. So as I mentioned, even mild anemia results in poorer health-related outcomes. So patients with heart failure whose hemoglobin measurements may still be low normal, they may already have more symptoms, poorer hemodynamics, and greater mortality. And as the elder increases in age, they are accompanied by all of these other conditions like increased frailty, poorer exercise performance, diminished cognitive function, and it becomes an iterative relationship with the anemia, and so they get worse and worse. So if you can address the anemia as early as possible, then you can prevent some of these problems from worsening, or you can prevent the elderly from feeling worse because of these other problems. So how do we diagnose? Well, of course, you're going to use your hemoglobin, but in addition to the hemoglobin, because about two-thirds will be caused by other conditions that are non-nutritional, it will help to do at least two other tests if they're available to you. So one is the mean corpuscular volume, and that actually can be I think this can be accessible to most laboratories. You can also use the peripheral smear that will provide you with some information about the corpuscular volume and serum ferritin. So so a hemoglobin, MCV, and serum ferritin would be the most helpful to guide you in your diagnostic workup. So the MCV is very helpful because you can, if you have a low mean corpuscular volume accompanied by a microcytic RBCs on your peripheral smear, this is strongly suggestive of iron deficiency anemia, especially if it is an acquired abnormality. If you have a congenitally low mean corpuscular volume, then you might be having thalassemia. But then you want, in the elderly, this is probably not the case anymore because they would have been diagnosed to have thalassemia much earlier. Then if you suspect that there may be problems with iron stores, then serum ferritin would be also important. Now, other tests, you might want to look for sources of chronic bleeding and chronic inflammation. And you can follow this graphic. I think these slides will be made available to you after my talk. So there are other other workups that you might want to consider. So it's a nice algorithm to guide you about how to identify the cause of anemia, which is really of importance among the elderly. Now, I have been asked, do you need to do routine bone marrow examination? No, I think it should be made on an individual basis. And I would give a therapeutic trial for treating a nutritional cause first. And if the patient does not respond, then that's the only time that I might consider a bone marrow examination for unexplained or intractable anemias. Then we will be discussing more closely therapeutic options in a few minutes. Uh, what is important in the elderly is close follow-up because they can deteriorate very quickly. So especially if your elder has poor appetite, is frail, whether or not they have comorbidities, then please consider close follow-up. If you are treating them, then target a hemoglobin between 9 to 11.5 to prevent thromboembolic risk, and consider the functional status always. Sometimes their hemoglobin might look okay, maybe it's 10 or 11, but if your elder has difficulty breathing or cannot do the usual things that they do, then you might want to investigate further. So let's talk about supplements. This, as I said, the therapeutic options that we're going to talk about will be mostly for nutritional anemias alone because the other conditions will require further workup. So for supplements, the most common supplements would include iron, B12, folic acid, and co-nutrients like vitamin C, D, E, magnesium, and selenium, which are important in the different pathways for the absorption as well as the um, uh, chemical processes in the body involving iron, B12, and folic acid. So right now you have a lot of options for these supplements. Just consider absorption issues and side effects. If you're going to need intravenous iron, then please infuse it very slowly because it can be painful. For diet, please consider not just diet alone, but also physical activity, because diet alone is not going to make your elder feel better. So consider their lifestyle, consider comorbidities and caregiving capacity in giving your dietary advice. It is better to provide them with the food that they want rather than the dietary supplements, because they will eat more if they like the food. Consider food beliefs and misinformation. There's a lot out there. Fresh foods in general are a better nutrient source, because the the nutrients are at their peak in when you are consuming fresh food. So you need to consider the seasonality or availability of the fresh food, especially for fruits and vegetables, and nutrient retention during the preparation. Taste, texture, hydration, frequency of bowel movement, these are all important considerations. It's not enough to just provide micronutrients. They need carbs, they need proteins. In fact, the protein requirements of the elder is almost double that of the younger adults, because younger adults will need zero point 0.8 grams per kilogram per day only. When they are old, because of higher breakdown, they are going to need 1.5 grams per kilogram per day. So consider all of the macronutrients as well. You need the fats also to absorb fat-soluble micronutrients. Now, to make them eat better and exercise better, it's always nice to have it in a social environment. So encourage them to eat and exercise with others. Now, let's talk a little about erythropoietin and erythropoiesis stimulating agents. Now, this is already in the realm of the specialists, but I think that the generalist will have to understand at least the principles behind it, because sometimes for nutritional anemias that are not responding very well to nutrients alone, you might need to give erythropoietin or an ESA, erythropoiesis stimulating agent, because the capacity of the kidney needs to be stimulated. So these are just some notes on how you might be using these two agents for your patients with anemia. So in conclusion, we have reviewed the different the global prevalence, the Philippine prevalence, the causes of anemia in the elderly, and the diagnostic workup. And we have discussed a little of the therapeutic options. So anemia in the elderly is really an extremely common problem, and it's associated with increased mortality and poorer health-related quality of life, regardless of the underlying cause. So we know that in the Philippines, about 23% of our males and 19% of our elderly females are anemic, and the management requires the consideration of both nutritional and non-nutritional causes and close follow-up. So maraming salamat po sa inyong pakikinig, and we look forward to your questions.
Thank you, Dr. Santos-Acuin, for that comprehensive talk. We now have 56 participants viewing through UP Manila live stream, 43 through YouTube Live, and 357 through Facebook Live, and groups viewing from all over the Philippines. We would like to thank Zuwelig Pharma Commercial Solutions for their support for this webinar. The floor is now open for questions from the audience. Just type in your questions in the Q&A chat box in the right lower corner
The Aging and Longevity Medical
of the live stream window, or type in comments in YouTube Live, or send personal messages to FB at Aging Webinars for Facebook Live viewers. Okay, we have the first question, Dr. Acuin. At what level of the hemoglobin do we advise blood transfusion for our elderly patients?
Okay, so as a general rule, I think they use 7 or 8 milligrams per deciliter. But I would look at the patient, because as I said earlier, some patients, even with relatively higher hemoglobin, already are already severely affected. And but in this case, you will have to look at the comorbidities because you might not want to transfuse whole blood. You need to look at the heart function of your patient. This patient might have a chronic renal disease or other comorbidities that will not allow them to accommodate the volume of whole blood transfusion. So you might need RBC transfusion for these patients. Also, if you want to rapidly increase the hemoglobin, let's say this is a patient that's being prepared for surgery, or this is a patient that you know will undergo chemotherapy and will need some kind of buffer or reserves because they're not very resilient patients anymore. So then in those cases, so maybe 7 or 8, as I said, hemoglobin would be the threshold.
Okay, thank you for that's for the need for
That's for
transfusion.
transfusion.
Yeah. And then next question would be, what is the most common side effect of giving iron supplements is gastric irritation, especially in the elderly. And would it be recommended to give a proton pump inhibitor in combination with the iron supplement to reduce gastric irritation? Sorry, that's from TJ Perlas.
Okay. Well, I'm a very conservative physician. So if
Okay.
I can avoid giving medication, I would, especially in these patients who tend to be taking a lot of other meds already. And so the risk of having a drug-drug interaction is high. So in the case where you are giving iron supplements and patients might experience gastric irritation, I would consider giving a form of iron that is less irritating. So maybe your iron gluconate, or you can also consider consuming the iron immediately after meals so that you can reduce the irritation. So try those things first before you use a proton pump inhibitor.
Okay. Yes, give after meals to
Yeah.
reduce the irritation. So what is a better oral iron supplement for, I think Dr. Acuin just answered this, but anyway, what is a better oral iron supplement for patients with gastroesophageal reflux disease?
I think it's the same. Yeah.
Yes.
So yeah, I would avoid ferrosulfate or elemental iron because those are the most irritating. And also if you can, there are now coated forms of iron. So use the coated capsules so that your gastric lining is protected.
Okay. So not sulfate as a first choice.
If
Gluconate
if
probably,
yes,
if
gluconate would
possible.
be, or even fumarate. It really depends on the way that the patients can tolerate the meds.
Okay. So this question is from Ruby de los Reyes. Would you recommend giving multivitamins to the elderly?
Um, if they do not eat as much as they need, yes. Also, if they do not eat regularly, because I have observed some elder patients where um, they skip meals or they do not eat on time, and so in that sense their intake is reduced. So it's not that per meal the intake is less, but overall over a day's intake, because they tend to skip meals or they tend to extend the non-eating period. For the day they eat less than their requirements. So yes, I would recommend supplements in those cases, and I would recommend multivitamins, um, even together with your iron supplement if you're considering iron deficiency anemia, because you need the other micronutrients for the absorption and metabolism of iron. So, for example, you need a vitamin C so that you can more efficiently absorb the iron. You need also DNE for the other enzyme functions, as well as magnesium and selenium. So, as a general rule, yes,
Multivitamins would
multivitamins
be,
for the elderly who
yes.
don't eat enough.
Okay. So we have another question from Danica Gabon. How long do we need to give iron supplementation? And what labs do we need to order? Basic ones, especially for resource limited areas, to check for therapy effectiveness.
Okay. Well, let me answer the last one first because your diagnostic options are really quite limited when you are in resource constrained areas. So maybe you will have just hemoglobin to guide you. Um, but as I mentioned earlier, if all you have is hemoglobin, or you can at least you can do a peripheral smear, and you can look at the characteristics of your red blood cells so that you can be guided about the kind of anemia that you are dealing with. So as I said, when it is iron deficiency, you will have microcytic red blood cells. When you have B12 or folate, you will have big RBCs. So, di ba? Kaya tawag sa kanila megaloblastic anemias. Um, so that can guide you about the deficiency. Now, if they kind of look normal, but your hemoglobin is low, then I would, give all three in a multi vitamin form. So iron plus B12 plus folate and the other micronutrients. Now, the lifespan of your red blood cell is about 120 days. So that's about 4 months. So at the very maximum, by 4 months, you should see something. Now, in some patients who are really very deficient, by 6 weeks, 8 weeks, you already see some changes in their hemoglobin. This is using oral treatment, huh? But definitely by 4 months, you should see something. And then you allow an additional 3 months, 2 to 3 months to replenish your, especially for iron deficiency, to replenish your iron stores. Um, but if after 3, 4 months you don't see any changes in your patient's hemoglobin, you should start working up these patients for other causes of anemia. The more common ones that are accessible to you in the primary care setting, accessible meaning you can treat them, would be some forms of chronic bleeding. Minsan kasi sa elderly, hindi yan napapansin, no? Bleeding sa gums or maybe occult bleeding because of gastritis. So start investigating, or maybe they have hernias, or they may have um, so other problems that will cause chronic bleeding.
Okay, so those will have to be corrected as well. Next question is, when is intravenous iron treatment indicated?
Okay, so um, intravenous iron has been used when you want to have a very rapid improvement in your hemoglobin. And as I mentioned earlier, these are usually the situations where your patient is severely dysfunctional, meaning the hemoglobin levels are so low that they're having difficulty breathing, or they cannot get up from bed anymore, they cannot walk around anymore, and whereas they used to, or they are being prepared for surgery or for other therapies that will require them to be in a better functional state. So these are the patients where you might consider intravenous iron. As I said, this is a very painful, although intramuscular is even more painful, and that's why that's not recommended anymore. It's better to just use intravenous. It's less painful, and there are better formulations now to make intravenous iron administration safer.
Okay, so it's basically for rapid correction of the iron level, the hemoglobin level. Okay, we have another question from Zinia Balagtas Gemino. Nakaka-anemia po ba ang pagpupuyat, especially for call center agents? Will this affect them when they become old?
um, if you are eating according to your requirements, so I'm assuming you're a call center agent, you're still relatively young. If you're eating according to requirements, you probably will not get anemic. The problem will be when you you do not eat a diverse diet. Usually, what I've observed from, and this is just from my relatives who are call center agents or friends of friends, what I've observed from call center agents is they tend to want to eat a lot of energy dense foods, probably to keep awake. So that means that might compromise their protein intake and the iron sources from their diets. Also, the other micronutrients needed for to have adequate hemoglobin, like even folate and B12, might be deficient in the young if you're not eating enough fruits and vegetables. So I think it's more the accessibility of food that is a constraint for many of these young individuals. So um, try to correct your diet first before you resort to therapeutic options. Now, this is not going to anemia in the young unless it is congenital in nature or it is due to a comorbidity, meaning if you have cancer or if you have HIV. In general, you're not going to carry that over into your elder years because it is really something, most of the time it's nutritional, you can correct it within a short span of time. So that's not a lifelong condition unless there is an underlying cause. That is the one that is lifelong.
Okay. So hindi naman yung pagpupuyat mismo eh.
Hindi yung pagpupuyat
yung
mismo. That's correct.
Yeah. Okay. So this is from Efren Plaza Molina. Hi doc, do you recommend ketogenic diet for elderly persons?
Well, I don't understand why you'd like to give a ketogenic diet to an elder. If there are, if the elder needs to lose weight, there are better ways of losing weight, because the problem is they usually cannot chew very well or swallow very well. And so if you're going to put them on a keto diet, the amount of the amount of protein-rich foods that they can eat, I think, will not be sufficient to meet their requirements. So, because you're going to take away the carbs, so that means you need to take a lot more of these protein sources. And if they cannot chew very well or swallow very well, that means they cannot take in as much as they need. And I already told you earlier that their protein requirements are almost double that of younger individuals. So it will be very hard for them to consume as much as they need if you put them on a keto diet. Also, these elders, they tend to have very irregular sleeping hours. I don't know if you've noticed that. I've noticed that in many of my elder patients as well as in my own relatives that they will wake up very, very early in the morning. Minsan 3 o'clock in the morning, 4 o'clock in the morning, gising na yan. And then 10 o'clock in the morning, tulog. Diba? Tapos hindi kakain ng lunch. Kasi tulog. Gising na yan, mga 2. O, tapos doon pa lang kakain ulit. Tapos pagdating ng 6 or 7, tulog na naman. Tapos gigising ng maagang maaga. So those irregular hours also, I think, are not going to be easy for you to consume, to meet your requirements of using a keto diet. So I think regularly spaced meals, I think I mentioned that earlier, and a balance of your macronutrients, so that means carbs, proteins, and fats, as well as your micronutrients, is still the golden rule for most people.
Sige, wag na mag-keto muna. Okay, from Eva Monfero. Would you recommend iron supplements for patients taking warfarin sodium? And what is the advisable number of milligrams that the patient can take? So this is for someone taking warfarin,
Hmm.
anticoagulation.
Yeah, I'll have to look that up, no. But I guess the premise there is that they might bleed because they're on warfarin, and that's why you'd like to give kumbaga, preemptive iron iron supplementation.
Uunahan.
Yes, uunahan mo na. If the patient is eating well, I would not recommend preemptive iron because you get a lot of side effects also from the iron itself. So you've mentioned earlier, you get bloating, you get some patients get constipated, some patients get diarrhea with iron, some patients get gastritis from iron, and that might be a cause for bleeding itself. So I wouldn't recommend preemptive iron supplementation in patients on warfarin. I would recommend a healthy and balanced diet uh, with good protein sources. So the more biologically available sources of protein are, of course, your meats, but in consideration of planetary sustainability, you might want to, instead of eating beef, eat chicken instead or eat fish. Um, and then eat plenty of fruits and vegetables. I think that's a safer recourse than giving preemptive iron.
Okay. Next question is from Delphine Soriano. I have an 81-year-old mother-in-law who was currently diagnosed with DM type 2 and hypertension as well as arthritis. What would be the best way to prevent anemia in her condition since she also has a poor to fair appetite only? Does
Okay.
anemia have a direct correlation with diabetes and hypertension?
Um, for the diabetes, I think there is evidence that patients who have diabetes and are anemic might be more symptomatic than others who are not anemic at the same time. This is one of those patients where I would give multivitamin supplement because if they're not eating well, that means they're not meeting their requirements. I would make sure that they are taking their medications, and I would discuss with your doctor or your endocrinologist the kind of diabetic medication that will not have a lot of side effects, because the problem with diabetes is some of the medications can cause very labile appetite swings. And that's usually because the medication needs to be more tailored. The dosing as well as the kind of medication needs to be more tailored to the patient's usual intake practices. So that needs a careful discussion with your doctor. What might help is to prepare a diary, a food diary of what your mother-in-law is eating, the times that she eats, the amounts that she eats, and then the usual times that you eat. So discuss this with your doctor so that the timing of the medications and the kind of medications can be adjusted so that you can optimize her intake. But really, poor appetite is not a good sign in the elderly. So I'm glad that you have noticed this and please do something about it.
Okay. So from Carlo Espinola, is it really advisable to take oral iron supplements with ascorbic acid to facilitate better uptake? So I think you mentioned
Yeah,
this
yes,
earlier.
yes, yes. It does help to absorb your iron better, but it doesn't need to be an ascorbic acid supplement. You can take a fruit juice or some other citrus form. You can eat an orange together at the time that you are taking your iron supplement. So if you can reduce the medications as much as possible, and I consider ascorbic acid tablet also as medication. Then and you can get it through food instead. That's a much more pleasant way of addressing your needs rather than resorting to pills.
Okay, and you get the other benefits from the
And
orange.
that's right. You get the other benefits from the orange too. You get the fiber, you get the other micronutrients.
Okay. Okay. Next question from Mary Jane Mapa. Is it advisable to discontinue the iron supplement if the patient is experiencing mild side effects? What can you advise?
Um, if this is a patient who's anemic, I would go back to your doctor and ask your doctor for a different form of iron. Or you can try what I advised earlier to take it with your meals or very soon after your meals to minimize the side effects. Um, you should not discontinue without telling your doctor because there is a reason why your doctor gave you iron pills in the first place. And if you just stop, that reason might get worse.
Okay. From Mercy Dita MD, I'm not available. What would be the interval or how often can you give intravenous iron? And what would be the grams per deciliter expected increase per session of IV iron?
Okay, I have to look at my notes there because this is not something that I usually do. Uh, in general, I think they only give it once a day, and there is a ceiling of the number of times that you can actually give intravenous iron. I hope I have it here in my notes. If not, I'm going to call a friend. Or maybe we can just reply to you separately for that because
Okay.
I don't want to make a mistake, especially about the dosing. But I recall that when giving intravenous iron, we just in general give it once a day.
Okay.
I don't have it on my notes here, so we'll respond to you separately.
We'll park the rest of the question for now. We'll go on to the next question from Ronver and Gracia. For patients who are Jehovah's Witnesses, aside from the IV iron sucrose, is there any other way of addressing anemia?
Um, so the limitation there is they are constrained for religious reasons about the types of foods that they can eat. So I think they cannot eat food with blood, um,
And they can't undergo transfusions.
and they cannot undergo transfusion. So in the case of food with blood, well, I don't know if they can eat fish. Fish has iron too. Chicken has iron if they can eat chicken. Um, If not, then there are iron sources. There are plant iron sources. But the problem with plant sources is they are less bioavailable. So if you're going to rely on plant sources for your iron needs, then you really have to take them together with a fruit, a citrus fruit, or a source of vitamin C, so that you can enhance the absorption. You can also how do you put it because it would help if you have some animal source protein together with your plant sources. So if you are allowed an animal source protein, even if you don't eat a lot of it, it already enhances the bioabsorption of the iron from your plant sources. So that's going to be helpful also for these particular
Okay,
patients.
so that's the option. Also here we have the call a friend. This
Okay.
is the for the administration of iron
But this is for IV iron.
for
IV iron ba to? Intravenous?
IV iron. Yes.
Okay, so it's a maximum of 1,000 milligrams per week. O weekly pa pala, hindi pa daily. Until your hemoglobin target is achieved. But you have to be very careful about giving IV iron because there are also a lot of side effects to IV iron.
Okay,
Okay.
that will be the last question because of time constraints. Thank you for all those questions for our audience. And once again, thank you, Dr. Acuin, for enlightening us with your answers.
Thank you very much for listening, everybody, and we hope you will listen again for our next session.
Yeah. Okay, I will just give a quick summary. So, about a fifth of our senior adults are anemic, as Dr. Acuin said, and we can use the mean corpuscular volume. That's very useful as a diagnostic parameter because it's strongly suggestive of iron deficiency anemia. And nutritional anemia is should be at the top of our considerations because this is the cause of one-third of anemias among elderly persons. Our target hemoglobin should be between 12 and 15 for our elderly persons. Okay, so thank you. Again, with that, we would like to thank Dr. Cecilia Acuin for taking time out of her busy schedule and sharing her expertise with us today. Please stay tuned for some reminders. Okay.
The Aging and Longevity Medical Webinars team of the Mu Sigma Phi sorority would like to thank our partners, the UP College of Medicine, UP Medical Foundation, and the Mu Sigma Phi Foundation. We are also grateful to support from the Postgraduate Institute of Medicine, UP Manila Information Management Service, and DOST ASTI, and the PRC Board of Nursing. Most of all, we thank you, our participants, for spending your lunch hour with us. We would also like to thank our sponsor, Zwellig Pharma Commercial Solutions. To receive your certificates of attendance, kindly answer the evaluation form by visiting the link on your screen within 2 days. The certificates will be emailed to your registered email addresses within 2 to 4 weeks. Here is a quick view of the schedule of our upcoming webinars. For more details and updates, please check our Facebook page at facebook.com/agingwebinars and our Twitter timeline at twitter.com/agingwebinars. Today's webinar recording and all webinar recordings may be viewed at YouTube at Aging Webinars channel. Please join us again on our upcoming webinar as seen on your screen. We are also announcing the launch of the OB Pearls book. Get your copies now. We would also like to invite you to attend the UP Med webinars every Wednesdays. Thank you and have a great day.